now that it's Monday, as we've done every Monday since this pandemic thing got itself going. We spent some time with our good friend, Dr. Dennis Norem from MercyHealth, discussing this very topic. Dr. Norem, good morning.
Good morning to you guys.
How's everything going with you this morning?
Well, so far good. Clear skies.
Yeah.
A little brisk, but a nice day.
How are plans shaping up for the Norem family Thanksgiving?
Pretty limited. Not going to be too many people in our house. Basically, just the two of us and my son and daughter-in-law who live here in the community, and my sister-in-law who also lives here in the community, and that's going to be about it.
Are you cooking?
I assist.
Okay. All right. Do the shopping.
Yeah, I assist too, but my wife keeps putting that in italics. I don't know why, but I guess when you're the guy washing the dishes, assist just makes you feel better about things. But
yes, I do help. I do help clean up, and I do help with the shopping. And then my next priority is to stay out of the way.
Okay.
It's a fine idea. We're looking at some of the numbers as far as travel for Thanksgiving, people visiting, people having a get-together like they would normally have. I think 38% is some of the numbers that came in an Ohio State poll had a little bit higher, and about 42% of Americans said they're still going to continue on like they normally would.
Yeah, that's a bit concerning that people are going to travel like they normally would. I heard that air travel's down about 50%, but that's still 50%. Is a fairly large number, which means there's going to be a lot of people going through airports, and probably not a desirable situation.
What's more concerning for the medical community, the travel, like you said, or the congregation in houses?
I think it's probably the congregation. There's some concern that airports are starting to become crowded, and there's been discussion about airplanes, but I think more recently the airplanes themselves are a less risky situation. But I think the problem is the congregation. A lot of people in a small, confined area, if one of them has the coronavirus, it spreads very rapidly.
All right, so yeah, the guidelines have been well, at first kind of released and then released again, and then over the past, I want to say 10 days or so, they've been hammering away. It seems like every single day it's a tap on the shoulder going, by the way, the CDC says you shouldn't be doing this.
Yeah, absolutely. A huge concern that this is going to really kind of add to our peak, and it appears that things may be slowing down a little bit across the country. I know some of the numbers from Illinois look like they might be tapering off a little bit. Unfortunately, not so much here in Winnebago, although I heard our most recent positivity rate dropped just slightly.
If Thanksgiving is the problem that a lot of experts think it might be as far as spread goes, how long is that going to take to show up in numbers? A week after Thanksgiving? 2 weeks? What's our time range there?
I think around two to 3 weeks. When you see the hospitalization rates bump up from these gatherings. So I think the critical time will probably be 2 to 3 weeks after Thanksgiving. You probably see positivity rates rise a little sooner than that, but then hospitalization rates are, of course, our big concern, as we've talked about before. As it's obvious that we're at capacity here in Rockford. I think there was a good article on what's happening at Swedish American in the newspaper over the weekend. Things are full. They're trying to find places to put extra beds. And the big problem is just staffing. There's just not enough staff to staff all of these extra beds.
Yeah, that's. I have a friend that's a doctor out in the suburb area, and she went down earlier this week, and a bunch of other people. You've been noticing the staffing issue in town here? Is that getting to be to problem levels?
Yes, talking to some of my colleagues, that it's a big concern that nursing staff is short, and staff has become affected like everybody else. So you could certainly add beds, but can you add staff? Where are you going to get staff? Because it's a problem all across the country.
And when we talk, real quick, one more staffing question. When we talk about ICU beds and ICU staff, how big of a difference of jobs is it from bringing somebody that isn't traditionally in the ICU area over from, general surgery, from, just not how big of a change in job requirements is it to go into the ICU area?
It's a significant change. The kinds of things that need to be done in ICU are a lot of skill set that a nurse that works elsewhere would not have without some significant training. I've been away from it for a while, but typically nurses that are ICU nurses typically take months to be trained to be able to staff the ICU. So that's a huge, huge problem. You can't just float people all over the hospital from a general medical bed down to ICU.
Yeah, several months, which we just haven't really had to prep everybody either.
And you mentioned we can't shift people from general to ICU, but it is something that is happening, right?
Yes, I think to some extent it is happening. One of the good news, I think, with the COVID is the patients that are hospitalized, a much smaller percentage have ended up in ICU and intubated because of treatment, things we've learned about oxygen therapy. So we're having a lot more patients on general medical floors who don't get nearly as sick and don't end up in ICU. But then you're back to the problem of just overwhelming the whole system in terms of beds and staff.
And then in comes the question about vaccines. I'm looking at a piece here from the Associated Press this morning talking about U.S. healthcare workers and others recommended for the nation's first COVID-19 inoculations could start getting their shots within a day or two of regulatory consent next month, according to a top official in the government's vaccine development effort. Says some 70% of the U.S. population of 330 million would need to be inoculated to achieve herd immunity from the virus, a goal the country could achieve by May. And this is the doctor who's chief scientific advisor for Operation Warp Speed. Thoughts?
Yes, I saw a number. December 12th might be the first day that we would see actual vaccine rolled out. I see that a third vaccine has come out to say that it's effective. It's the one from Oxford, I believe.
Yeah, AstraZeneca and their COVID-19 vaccine in conjunction with Oxford University, up to 90% effective in preventing.
And so I'm sure they're going to be applying for their emergency authorization soon. So that's more good news. I think that we are making great progress, and that's very encouraging. The one concern in all of that is none of these vaccines are approved for children. And discussion about when there would be approval for children isn't clear. Probably the earliest that there would be approval for children would be May or June of next year. So that's going to be a huge issue in terms of getting herd immunity and getting kids vaccinated.
Another plus with the AstraZeneca one is apparently theirs does not need to be stored at ultra cold temperatures, making it far easier to distribute in developing countries.
Yes, I believe the AstraZeneca one is a more traditional, like we're familiar with. It's more similar to the flu vaccine that we typically get, which is much easier to store and distribute than the new messenger RNA vaccines that have been already approved.
Hopefully we're not putting the cart before the horse on this one, but with now 3 vaccines in play for possible distribution here soon, should we figure out which one we want to take? Will this be decided by the hospital or doctor we go to? How do we decide which of these vaccines are ultimately going to be put in us?
I suspect it will be decided by the distribution situation. I think the Operation Warp Speed people are going to make a decision about where to get it and who to send it to. Now, the one vaccine, though, I think they're going to work through some of the pharmacies. So I think the bottom line is when you're able to get it, whichever vaccine it is, you'll want to get. I don't think, unless there's some change in the way they're going to approach this, That's the way I look at it. Whenever they say I can get XYZ vaccine, I'm going to take whichever one is available.
So if my doctor offers the Pfizer one, but for whatever reason, if I'm really into the Moderna one, I shouldn't be shopping around looking for, my optimal vaccine?
Absolutely not.
Okay.
The sooner the better. And again, whichever one's available to you, you should get down there wherever and get it.
Yeah, as quickly as you possibly can. Another bit of treatment that is getting some news, the FDA yesterday made the announcement of authorizing, you'll have to help me here, monoclonal antibodies for treatment of COVID-19.
Yes, that treatment from, I think it's Regeneron, their version of the monoclonal antibody, which combines, I think, 2 different monoclonal antibodies, is now an approved treatment. It's been used for compassionate use, and I believe the president received that when he was ill. But yes, that's another very encouraging development. It appears to be very effective in treating people who are ill with COVID.
So this wouldn't be a vaccine to prevent you from getting it, but should you wind up with it, then this would be a treatment that would be administered to you to try to get rid of it.
Correct. There's no evidence yet, I think, that it's a preventative. It would only be for actual treatment of patients who are positive, who are ill enough to probably be hospitalized. I don't believe it's something that's going to be given to people in the outpatient setting, but that remains to be seen.
A testing question. We've been focusing a lot on testing whether or not you have coronavirus or not. Where are we at with antibody testing for maybe people that think they may have gotten it, in January or February before this was a big story, and maybe find out that they're quote unquote immune for the time being? Where's antibody testing right now?
Well, I think they're using the antibody testing to really try to find people to get convalescent serum from. I know the blood bank is advertising that they can do antibody testing because they want your convalescent serum. I don't know that we've really got to the point where anybody's being encouraged to get antibody testing just to see if they've had it. Excuse me. So I think the antibody testing is there. The problem with antibody testing is it's still not 100% clear that if you test for antibodies, if you're negative, that means you've not been exposed, which creates some problems that people who have already been exposed may not show up with some of the antibody testing. Because at the end of the day, there are different antibodies in the body, and some people are able to fight off COVID without producing a specific antibody that you can test for.
Okay, yeah, I had no idea on this one. Back to the keeping Thanksgiving, limited and well, for lack of a better term, I guess quiet. And we should be looking, a couple of weeks down the road to see, what percentage of people actually went along with that, because we can look at hospitalization and all that. What if a couple of weeks after Thanksgiving we don't see any blips? We don't see any spikes. What's that going to mean as we move forward? Because, we're not done with the holiday season yet.
Well, that would be encouraging news that maybe this wave is starting to lose its oomph and we're going to see us move on the downside. But then that brings up the concern about Christmas. If we see a significant drop in cases, does that mean people are going to drop their guard and say, oh, now we can all start traveling and we can get together for Christmas? So it's kind of good news, bad news situation. I hope that we don't see a spike. I would hope that maybe we just see things level off, and then people can see that limiting travel can be effective, and we can get through Christmas and kind of get to the other side of this thing.
And then, one last question here. Going back, masks back in the news this past week. There was a Danish study being passed around a lot this past week, stating, maybe masks not as effective as we initially thought, as far as protecting the user. Even those that released the study said that really this shouldn't be used for anti or pro-mask agendas. We still any new news in the medical community as far as mask usage? Still use them, right? Everything's on the up and up.
No, I don't think there's anything new. I think it's back to having an effective mask, one that has at least a couple layers of good material. And the problem, of course, is we all see this, is people simply don't keep their mask where it needs to be. People don't have their nose covered. They just don't pay attention. And many of the masks that I see are just not adequate in terms of covering the face. So, unfortunately, we know masks are effective. They're not 100% effective. And if they're not the right size and not worn right, they're even less effective.
The no-nose thing is fascinating to me.
Yeah.
If you're going through the whole rigmarole of throwing the mask on, pull it up 2 inches.
Yep, I see it all the time. All the time.
Yeah, that's the biggest issue I see too. I was at the grocery store yesterday helping my wife to get the food for Thanksgiving, and there's somebody standing there and the mask is below their nose, and it's like, why bother?
Exactly.
Right.
Why bother?
Why bother? Yeah, he thinks it saves him from verbal assault. Having it that far saves you from verbal assault. Although I have seen people loudly and clearly point out that's a chin diaper that you're wearing. It isn't helping out.
Yeah, absolutely. So people wear a mask, make sure it's big enough, cover your nose, and change your mask frequently. I mean, don't wear the same mask for a week at a time. Please have multiple masks and rotate them.
Look at masks like underwear.
Yes.
Yeah, remember, guys, don't be a mask hole.
I got to get that bumper sticker. Dr. Norem, as always, we appreciate the time. We appreciate the expertise. We wish you and your family a wonderful, wonderful Thanksgiving. And if you're up for it, we'd love to talk to you again next Monday.
We'll see you next week, guys.
We
Have a good
appreciate it.
Thanksgiving.
You too. That's Dr. Dennis Norem from MercyHealth.